This lecture is sort of a compilation of a few different classes of disorders, though they share some similarities with one another. We'll start discussing the disruptive disorders, which are typically childhood disorders that involve difficulty controlling one's emotions and behaviors. Then we'll discuss the developmental disorders, which are those that necessitate onset in early development or childhood, but are broader in content than the disruptive disorders. Finally, we'll discuss the impulse control disorders, which can be diagnosed in children or adults, but similar to disruptive disorders, involve difficulties controlling emotions and behaviors, manifested as inability to control urges or impulses to engage in certain behaviors. There are two disruptive disorders: oppositional defiant disorder, or ODD, and conduct disorder. ODD is diagnosed in kids who display a pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness. Specifically, they need to demonstrate at least 4 of 8 behaviors. These kids frequently lose their temper, which can be manifested either verbally by yelling at others or physically by doing things like hitting or pushing others. They're easily annoyed or irritated by others' behavior, and they frequently appear angry, and they are likely to resent others, often because they are prone to view the world as treating them unfairly. Interestingly, they're not very likely to actually describe themselves as being angry individuals. Instead, they tend to justify their behavior as a response to unfair or unreasonable demands or circumstances. They argue with others often, especially adults or authority figures, like parents, teachers, or coaches. In fact, they frequently refuse to do what adults ask of them or to follow specified rules. Despite being easily annoyed by others' behavior, they often purposely try to annoy other kids or adults. When they make mistakes, they are likely to try to place the blame on someone else, or at least refuse to take responsibility, again, believing they are the victim of unfair circumstances. Finally, they may engage in frequent vindictive behavior, at least 2 times per week, where they do something to get back at someone who has wronged them. These behaviors must be present for at least 6 months and either cause distress to the kid or others in his or her social environment, or it impairs the kid's functioning. This actually means that the kid may not be distressed, but he could still get the diagnosis if he is significantly impairing others, such as other kids in his classroom at school, due to his behavior. Typical examples of impairment that these kids may experience are being suspended or expelled from school, or experiencing extreme interpersonal difficulties. You'll note that nowhere in the diagnostic criteria does it comment on age. Technically, an adult could get this diagnosis, though I've never known that to be the case. If an adult continued to experience these symptoms, he'd probably be diagnosed with another disorder, possibly antisocial personality disorder, if he also engaged in social norms and law-violating behavior. But generally, we only see this particular pattern of behavior in kids. Some people may take issue with this diagnosis, believing that it's an example of overdiagnosis of mental illness, or overpathologizing typical behavior, especially what we might see in little boys. Right, lots of little boys are defiant and argumentative and refuse to take responsibility for their actions. But the thing is, sometimes this can become so extreme that it becomes really problematic for the kid. Though my friend's brother was never given an official diagnosis of ODD, at least not that I'm aware of, I'm confident he could have been diagnosed when he was in elementary school. He personified these symptoms, especially at school. Ultimately, this resulted in him getting a reputation of being the bad kid, and this was prominent across the school, both with other kids and teachers alike. ODD is a disorder that most kids with a diagnosis will sort of age out of or grow out of. It doesn't tend to persist, which is also why we don't tend to see adults with this diagnosis. So with my brother's friend, by the time he was in 5th grade, he actually demonstrated very few ODD symptoms anymore. However, his reputation stuck with him, and he became unfairly targeted as a scapegoat for other kids' bad behavior. And the teachers were likely to believe that it was him who did something wrong, when it really wasn't. In addition, he had no friends because of his past bad behavior. When it came time to move to middle school, instead of putting him in the school he was in the district for, alongside the other kids he went to elementary school with, his mom got him placed in a different school where he had no prior reputation following him, and he ended up doing very well. I tell this story just to indicate what types of impairing consequences, some of which could be long-lasting, can stem from symptoms of this disorder. We will also diagnose ODD with a specifier, which is determined solely based on the number of settings in which symptoms are present. If symptoms are only present at school and nowhere else, for example, it is mild. If symptoms are present only at school and home, but nowhere else, it's moderate. If symptoms are present in at least 3 settings, then it's severe. As I've mentioned previously, conduct disorder can be thought of the kid version of antisocial personality disorder. It too involves persistent violations of the rights of others or the norms or rules of society. For diagnosis of this disorder, the person must demonstrate at least 3 out of 15 possible symptoms that are grouped into 4 categories: aggression to people and animals, destruction of property, deceitfulness or theft, and serious violations of rules. Diagnosis does not necessitate symptoms across 3 different categories. It only requires 3 symptoms total across any of the 4 categories. The 3 symptoms must have been present within the last 12 months. This does not mean that symptoms need to have been evident for a full year. It's just that the 3 symptoms must have all persistently occurred within the same 1-year time period. In addition, to ensure that the diagnosis is current, at least one of the symptoms must have been present in the past 6 months. So, for example, the kid may be demonstrating 2 symptoms over the last few months, but he also demonstrated another 1 or 2 symptoms prior to that, but within the last year. That would be sufficient for the diagnosis. These symptoms must cause significant impairments in social, academic, or occupational functioning. Note that the criteria does not include distress. Many kids with conduct disorder may not be distressed, similar to people with antisocial personality disorder. However, their symptoms are likely to cause impairment as they are likely to experience problems making friends or succeeding in school. Finally, age needs to be taken into account. If the person is 18 years or older, it must be clear that they do not meet criteria for antisocial personality disorder. Recall that the criteria for antisocial personality disorder includes that the person must be at least 18 years old, and that there's evidence of conduct disorder symptoms in childhood. Thus, for most kids who demonstrate conduct disorder symptoms and persist in doing so after age 18, it's likely that their diagnosis will switch from conduct disorder to antisocial personality disorder. While it's possible that an adult could be diagnosed with conduct disorder, I have never actually seen this occur. Given the specific symptoms for conduct disorder, which you'll see on the next 2 slides, it's likely that by the time the individual was 18 years old, that they would progress to engaging in rule-breaking behavior more consistent with adult behavior, rather than behavior more relevant to kids, which is what the conduct disorder symptoms apply to. In our first category of symptoms, aggression to people and animals, we have 7 possible symptoms. The child may often bully, threaten, or intimidate others. They may also start fights with others, specifically physical fights, and they may have used a weapon that could cause serious physical harm to others, such as a knife or a gun. There may be evidence that the child has been physically cruel to other people as well as animals. To be clear, the symptom related to cruelty to others and animals is indicating that this is beyond what would be expected from most kids. For example, siblings may push or hit each other, or little kids may purposely kill bugs. This is not what the criteria here is getting at. Instead, there must be evidence that the kid is demonstrating truly cruel behavior, like torturing others or animals. For example, seriously harming or killing the family dog. Next, there may be evidence that the child has stolen something while confronting their victim, such as forcing another kid to give them their money or toys. Finally, the child may have forced someone into sexual activity. The next category of symptoms is destruction of property and includes 2 possible symptoms. The first is that the child has deliberately set fire to something with the intention of causing serious damage. This is fundamentally different from someone who accidentally sets a fire and causes damage, and from someone who could be diagnosed with pyromania. We'll discuss pyromania later in this lecture set, but it includes fire setting because the person is fascinated with fire and can't resist the impulse to set a fire. Importantly, they don't actually want to cause damage or harm to others. Fire setting in conduct disorder is not being done because the kid is fascinated with fire. It's being done to purposely cause serious damage or harm. Or, the child might deliberately destroy others' property. Usually, this is more than something like breaking their sibling's toy, and instead is something that causes more serious destruction, like breaking windows of houses or cars. The third category includes three symptoms and is deceitfulness or theft. First, the person may have broken into someone else's house, building, or car. Next, the person might be likely to frequently lie, specifically for the purpose of obtaining items or favors or to avoid having to do something they don't want to do. These lies are being done to manipulate or con others. It's not a simple white lie. Finally, it's possible that the person may have stolen items of non-trivial value, meaning expensive items, without confronting a victim. Recall that there was an earlier symptom that the person has stolen while confronting a victim, and I gave the example of stealing a toy or lunch money. Those would be trivial items, and so for that to count as a symptom, the person must have confronted the person they were stealing from. If the person steals something without confronting their victim, as could be done if they broke into someone's house when they weren't home, it must be something that is expensive, like a computer or TV, or large sums of money. Finally, the last category is serious violations of rules and includes three possible symptoms. The first is that the child often stays out at night, even though his parents have not given him permission. Importantly, there must be evidence of this prior to age 13, as we would consider it more normative for older teenagers to disobey their parents and stay out later. So for this to count as a symptom, it must be occurring at age 12 or younger, which is an age at which we would not expect this to occur. Next, the child may have run away from home overnight at least twice. Finally, the kid is frequently truant from school, again starting prior to age 13, when we wouldn't expect this to occur. To put this into context, this is a kid in like 5th or 6th grade who frequently skips school, not a high schooler. As a reminder, though there are 4 categories of symptoms, the categories are only present to help organize the symptoms. The child does not need to have symptoms in a specified number of categories for the diagnosis. They just need to have demonstrated at least 3 symptoms total across any of the categories in the past year. Conduct disorder is diagnosed with severity specifiers based on number of symptoms present and severity of harm caused to others. Mild conduct disorders indicates that the person experiences only around 3 or 4 symptoms and they cause minor harm to others, while severe conduct disorder indicates that the person demonstrates a large number of possible symptoms and causes major harm to others. I discussed ODD and conduct disorder together in this section because they're both disruptive behavior disorders, but it is important to acknowledge that they are distinct disorders. Having a diagnosis of ODD is a risk factor for conduct disorder, but it is just that. Most kids with ODD do not go on to have conduct disorder. Yet, most kids with conduct disorder do have a history of ODD. The onset for both of these disorders is nearly always prior to age 16, and most often much earlier than that. ODD is likely to start during elementary school and is usually apparent by age 8, while conduct disorder symptoms are more likely to emerge in later childhood or early adolescence. For both disorders, symptoms are most likely to remit or go away by adulthood. That is to say that most kids with either of these diagnoses are not likely to continue demonstrating these types of symptoms as adults. However, early development of these symptoms, specifically early development of conduct disorder symptoms, is more predictive of later developing antisocial personality disorder. Both disorders are more common in boys, and prevalence rates range up to 10%. We'll discuss etiology and treatment for both ODD and conduct disorder together, as they're thought to have common causal factors. With regard to biological factors, it's thought that there's too little serotonin. In addition, given the link between conduct disorder and antisocial personality disorder, many of the biological etiological factors relevant to antisocial personality disorder are likely also related to conduct disorder, such as disruptions with the behavioral activation and inhibition systems. With regard to psychological etiological factors, kids with these disorders are likely to experience rejection from peers, which may cause or exacerbate some of their symptoms. They may have inherited or learned high levels of aggression, and they may also have failed to learn appropriate social skills. If kids are behaving aggressively and are not very socially skilled, other kids may be likely to reject them. This may cause kids to demonstrate symptoms of ODD or conduct disorder, whereby they are angry or act spitefully towards other kids, or they bully or threaten other kids. Because they're rejected by many peers, they end up associating with the similarly rejected or deviant peers. This association further exacerbates their symptoms. They start spending time with kids who are also aggressive and socially unskilled, and so they further learn poor behaviors. Finally, kids with conduct disorder are likely to have experienced both harsh and inconsistent parenting. Parents may be poor monitors of behavior, and so poor behavior is not reprimanded consistently, nor is good behavior reinforced consistently. Further, parents may engage in aggressive behaviors themselves when doing punishment, which the kids are likely to model. Unfortunately, many kids with ODD and conduct disorder tend to be punished rather than treated or rehabilitated. It's likely that some kids with conduct disorder will end up in the juvenile detention system. Earlier treatment for all disorders is always better, so it is important that these kids get some treatment when these types of symptoms are recognized to try to prevent the progression to antisocial personality disorder. SSRIs have been prescribed due to the thought that these symptoms might be related to deficiencies in serotonin. However, there's not strong evidence that they're very effective. The cohesive family model has demonstrated efficacy in reducing symptoms of ODD and especially conduct disorder, but it can be difficult to implement because parents may not be willing or able to engage in the treatment, which is a necessary component. As it's thought that the parents of kids with conduct disorder may be lacking in some parenting skills and behave in inconsistent ways, thereby reinforcing inappropriate negative behavior. This treatment focuses on restoring functional patterns of behavior between parents and child. Finally, some simple behavioral techniques can be applied to decrease symptoms of ODD and conduct disorder. One way is to find alternative and acceptable outlets for the child's aggression, such as getting him involved in sports. In addition, starting to include positive reinforcement of positive behaviors, both at school and home, can increase the frequency with which the child is engaging in desired behaviors, which consequently decreases the frequency of unwanted behaviors. We'll next discuss the developmental disorders. As I previously mentioned, these disorders start during the developmental period, which typically means childhood. All of the disorders in this section must have their onset at least by age 18, and many of them will actually specify a much earlier age of onset than that. For all of these disorders, the diagnosis would not be possible if symptoms did not start until adulthood. We will discuss 5 categories of disorders in this section of the lecture, starting with intellectual disability. Intellectual disability used to be called mental retardation, but it was renamed in the current version of the DSM. The first criterion is that the person must experience deficits in their intellectual functioning, meaning their reasoning, judgment, ability to learn, planning, and problem solving. This must be indicated in 2 ways, both by clinical assessment, meaning through interviews and conversations with a practitioner, and through standardized intelligence testing. This means that the person would undergo something like an IQ test to confirm that their intellectual functioning is below where it should be for their age. IQ is a construct that falls along a normal distribution. We know that the average IQ is 100 with a standard deviation of 15. The standard deviation can help us understand how atypical a score is relative to the mean. Specifically, we know that only 2.5% of the population has a score more than 2 standard deviations below the mean. This means that only 2.5% of people have an IQ below 70. Although this benchmark of an IQ less than 70 is not specifically included in the diagnostic criteria, that is the typical rule of thumb used by clinicians for this criterion, though there is a little flexibility on either end. For example, someone with an IQ of 68 doesn't necessarily have intellectual disability. On the other hand, intellectual disability could be diagnosed in someone with an IQ of 71 or even 72. Importantly, it's not just IQ that the clinician is attending to for the diagnosis. The person must also experience problems with adaptive functioning. Adaptive functions refer to life skills such as communication, personal care, money management, recreational engagement, interpersonal skills, and health and safety. These deficits in adaptive functioning are extreme enough that they result in the person being unable to fully live independently and participate fully in society. Thus, in at least one area of adaptive functions, the person must have substantial enough deficits that they need substantive assistance from others. For example, they are unable to manage their money and require someone else to do that for them. Or they cannot keep themselves safe when cooking or caring for their house, and they need assistance with that. Finally, the diagnostic criteria indicates that the onset of these problems must be in the developmental period, or early in life. Here's why this is important. What diagnosis might you give an elderly person who's experiencing these symptoms, but prior to a year or 2 years ago, they did not have any intellectual or adaptive functioning problems? That person would probably be diagnosed with dementia. Or for another example, would you diagnose a 25-year-old with intellectual disability who only recently developed these symptoms following a bad car accident? No, that person is probably likely experiencing a traumatic brain injury. So in order for the diagnosis to be an intellectual disability, these problems must be apparent early in life. Intellectual disability is always diagnosed with a specifier depending on IQ. Most people with intellectual disability fall into the mild category, which is designated by an IQ greater than 55. People with mild intellectual disability have intellectual levels comparable to an 8 to 11-year-old. They often require some level of supervision in their daily activities, but can become self-supporting in many areas with some assistance. Moderate intellectual disability includes people with an IQ between 40 and 55. Their intellectual level is similar to that of a 4 to 7-year-old. They can achieve partial independence and master routine skills if provided with specialized instruction. For instance, they may be able to be employed in janitorial work or food service or preparation. Severe intellectual disability includes people with an IQ between 25 and 40. They tend to have underdeveloped speech and motor skills and will always need to depend on others for care. Finally, profound intellectual disability includes people with an IQ under 25. They will be unable to master anything but the simplest of tasks and will remain in custodial care for all of their lives. Whereas people with milder and more moderate levels of intellectual disability may be able to live in supportive group homes or perhaps even independently. The prevalence of intellectual disability is at 1%, and it tends to be more common among boys. This will be a common theme among the developmental disorders, as they tend to be diagnosed more frequently in boys. Intellectual disability can be due to either genetic or environmental causes. A common genetic cause is Down syndrome. All kids with Down syndrome will have some form of mental retardation. Other genetic causes include Fragile X syndrome, which results from chromosomal abnormalities, or PKU, which results in intellectual disability if significant levels of certain amino acids in foods are ingested. Environmental causes include early infections, either during fetal development or shortly after birth, maternal drug or alcohol use during fetal development, physical injury, again either during fetal development or early in life, exposure to high levels of radiation, or early malnutrition, again either during fetal development or early in life. There is no cure for intellectual disability. These individuals will always have deficits in intellectual and adaptive functions. However, modeling and specific instruction and skills can be helpful. Beginning in childhood, the practice of mainstreaming is now common. This simply means that kids with intellectual disability are included in the same classrooms as typical kids, and they just may receive additional or separate instruction with regard to specific academic skills. But otherwise, they are exposed to the same content and experiences as everyone else. This may seem like a no-brainer to you, but mainstreaming is actually a relatively new practice. When I was in elementary school, mainstreaming was not the common practice. Kids with intellectual disability were kept in a separate classroom where they were only exposed to typical kids at recess. This took away opportunities for learning through modeling behaviors of typical kids, and it also resulted in stigma. Thus, mainstreaming in schools is now recommended to assist in developing both behavioral and social skills. In addition to learning some of these skills through modeling others' behavior, specific instruction can be provided to kids with mild and moderate intellectual disability to enhance their adaptive functioning so that they can learn to be independent in certain areas. For people with more severe intellectual disability, behavioral management becomes important to keep them and others safe, and this is done through simple operant conditioning procedures. For example, providing positive reinforcement for wanted and adaptive behaviors, and punishing inappropriate behaviors either by ignoring or removing privileges. Finally, as I'd indicated previously, some people with intellectual disability, particularly those who need substantial supportive care, may be institutionalized or may live in less restrictive group homes where there is round-the-clock care or assistance. We'll now move on to ADHD. I'm sure that you've all heard of this disorder. For this disorder, the individual must demonstrate persistent, inattentive, or hyperactive impulsive symptoms. Some kids will only have inattentive symptoms, while some kids will only have hyperactive and impulsive symptoms, and yet other kids will have both types of symptoms. I'll go into more detail about what these symptoms are in the next few slides. An extremely important diagnostic criterion to pay attention to is the second criterion that states that at least some of the symptoms must have been present prior to age 12. This is to highlight that ADHD is a developmental disorder. It will never suddenly begin in later adolescence or early adulthood. I know that many college students want to be evaluated for ADHD because they're having a hard time or difficult time studying or paying attention and doing well in school. Part of the assessment of whether that student truly has ADHD needs to include evidence, either through something like parental reports or old school report cards, that these difficulties were occurring in childhood. If there is absolutely no evidence of that, then the person does not have ADHD. It must begin early in life. So to be clear, a person can be diagnosed with ADHD for the first time as an adult, but it must be clear that the symptoms actually started in childhood. Next, several of the symptoms must be present in at least two settings, such as both at home and at school. This is to rule out some kids who may have behavioral issues in one setting, and not truly ADHD. For example, maybe a kid can't sit still and doesn't pay attention at school. So he might look like he has ADHD, but if these symptoms aren't also occurring in another setting, it's more likely that the kid is just bored or doesn't like school, and so is acting that way in response to that, not actually due to ADHD. Finally, the person must be experiencing significant social, academic, or occupational impairment. Specifically, academic and occupational impairment is likely to occur if the kid can't pay attention in school or at work. And social impairment may occur if the person demonstrates a lot of hyperactive and impulsive symptoms, which may irritate others. There are 9 possible inattention symptoms. A person needs to endorse at least 6 of these, unless they are 17 or older, and then only 5 are needed. Clearly, all of these symptoms reflect deficits in the person's ability to optimally pay attention or attend to stimuli. So first, the kid might make careless mistakes because he's not paying good enough attention. So this would be a kid who rushes through his homework and ends up getting a lot of the problems wrong. Not because he doesn't understand the material, but because he's just not paying close enough attention. Or he may not be able to remain engaged in tasks or play activities, even ones that he likes. Lots of kids have trouble remaining focused and engaged with boring things like cleaning or doing homework. But kids with ADHD have trouble even with things that they enjoy, such as playing video games or watching their favorite TV show. For example, it may be truly difficult for a kid with ADHD-related inattention symptoms to sit still and focus on even a half-hour TV show. Next, kids with ADHD may not seem to listen when you're speaking directly to them, and likely seem as if their mind is elsewhere. Others, like parents and teachers, will frequently state that they have a hard time getting the kid to listen to them when they're talking, even if the conversation is directed specifically at them. They're also not good about completing tasks that they have started, even with specific instructions and reminders to do so. So they may frequently start engaging in activities like homework or chores, but they get distracted partway through and stop. They also have difficulty organizing multi-step tasks and activities and knowing where to start and figuring out what step comes next. This is primarily due to the fact that it's difficult for them to take the time to plan out these steps and think through their actions beforehand. Because sustaining attention is difficult for them, these kids will often try to get out of engaging in activities that they know will require a lot of mental effort. They purposefully avoid tasks that they know will be difficult for them to attend to for longer periods of time. These kids also frequently lose or misplace things because they're not paying attention to what they're doing with their belongings, such as leaving their coat on the bus or at the playground, and they're often forgetful about things that they are supposed to do during the day, resulting in frequently missed appointments. Finally, they are easily distracted by things in the environment or even internally, like their own thoughts, and they easily forget what they were doing or get distracted with daily activities. Again, even when they're doing enjoyable activities. The other set of symptoms are the hyperactive impulsive symptoms. Again, there are 9 possible symptoms, and a person needs to endorse at least 6 of them unless they are 17 or older, in which case only 5 are needed. First, these kids seem to never be able to sit still. They are constantly getting out of their seat when they're not supposed to, such as while at school or at the dinner table. While in their seat, they constantly fidget around, often kicking their legs, rocking in their chair, drumming their fingers, or touching all sorts of objects nearby. When they're not sitting, they are often running around and climbing on things, such as desks or tables or dressers. In adults, this may be described as feeling restless or being uncomfortable sitting still. Others may describe people with ADHD as being constantly on the go, or moving around so excessively that it's like they're driven by a motor. They have difficulty relaxing and engaging in quiet, leisure activities. Instead, they talk excessively and have difficulty relaxing or resting without needing to talk or fidget or to get up to move around. They have a hard time inhibiting many impulses, specifically difficulty waiting their turn, not interrupting others, not waiting to be called on to answer a question, or not waiting until the person has finished talking before answering. ADHD is diagnosed with one of 3 subtypes, depending on the specific symptoms the person displays. If a kid has 6 or more inattentive symptoms and fewer than 6 hyperactive impulsive symptoms, he would be diagnosed with ADHD predominantly inattentive presentation. If a kid has 6 or more hyperactive impulsive symptoms and fewer than 6 inattentive symptoms, he would be diagnosed with ADHD predominantly hyperactive impulsive presentation. If he has 6 or more inattentive symptoms and 6 or more hyperactive impulsive symptoms, he would be diagnosed with ADHD combined presentation. So to be clear, a kid could have 8 inattentive symptoms and 4 hyperactive impulsive symptoms, and this would qualify him for the diagnosis of ADHD, predominantly inattentive presentation, and not the combined presentation, even though he has 12 symptoms altogether. This is because at least 6 symptoms are needed in both domains for the combined subtype. Of course, the exception is if the person is age 17 or older, and then only 5 symptoms are needed in each category. I'm sure many of you have heard of ADD or simply attention deficit disorder. This is actually not a diagnosis. People may use this to refer to people with ADHD who only have inattentive symptoms, but the accurate diagnosis should actually be ADHD predominantly inattentive presentation. ADHD is also diagnosed with a severity specifier. Mild severity indicates that the individual has few symptoms in excess of those required to make a diagnosis. So for example, they just have right around 6 or 7 symptoms, and their impairment is mild. Severe indicates that the individual exhibits nearly all of the symptoms and they have major impairment. ADHD is more common in boys. It affects about 5% of kids. About half of those kids will go on to continue to have these symptoms in adulthood. Remember again that this disorder never starts for the first time in adulthood. However, the subtype may change in adulthood. It's much more common for adults to have the inattentive type than the hyperactive impulsive subtype. So you may see that especially kids who are diagnosed with a combined presentation may switch to only having inattentive symptoms later in adulthood. Researchers still do not have a fantastic understanding of the etiology behind ADHD, but it's definitely at least partly biological. ADHD does run in families, likely through inherited temperament. Specifically, it seems that inheriting low levels of behavioral inhibition and high levels of sensation seeking may be related. Remember that behavioral inhibition refers to the tendency to approach novel and unfamiliar situations hesitantly and fearfully. So kids with very low levels of this are more likely to readily and easily approach and engage in novel situations. perhaps reflecting their hyperactive or impulsive behavior. Sensation seeking is the tendency to seek out and enjoy risky and stimulating behavior, again clearly related to hyperactive and impulsive symptoms. There are also clearly disruptions in neurotransmitters, specifically dopamine and norepinephrine. I'll come back to this when I discuss treatment. People with ADHD have also been found to have somewhat smaller brain volume, indicating a biological link. Additionally, when the mother smokes while pregnant, it is a risk factor for the child developing the hyperactive impulsive subtype of ADHD. So clearly something about nicotine seems to be biologically affecting the kid's development in the womb. With regard to psychological factors, disruptions in the family environment, such as frequent marital conflict or poor parenting practices, such as not providing consistent discipline or reinforcement, can contribute to symptoms of ADHD. The primary means of treatment for ADHD that is most frequently used is stimulant medication. Prescription stimulants are dopamine agonists. They increase the amount of dopamine available, because it's thought that kids with ADHD have too little dopamine. Common stimulant medications are Ritalin, Adderall, and Concerta. Though it may not appear to make sense to give a kid who's already super hyperactive a stimulant, which for most people speeds them up and makes them more active, the reason that it works for kids with ADHD is because they are behaving this way because they have too little dopamine. So their activity level and attention is not being appropriately regulated. You can think about this in the same way that we talked about arousal and underarousal for antisocial personality disorder. Individuals with antisocial start out being too underaroused, and so need to engage in risky behavior to become optimally aroused and perform well. People with ADHD have too little dopamine, which dysregulates their behavior. With the addition of a dopamine agonist, their dopamine levels become restored to their optimal level, and now their behavior and attention is regulated, and they actually calm down and can focus more. Though stimulant medication is fairly effective, it still doesn't work for everyone, and there are some negative side effects related to stimulant drugs in general. Kids may have difficulty sleeping, their appetite is suppressed, and they may experience some body twitches, because those are side effects of stimulants. Ritalin, in particular, has also been found to suppress growth. Not by a whole lot, but it's thought that the person will not reach their full height potential if they use Ritalin consistently as a child. There is also the potential for abuse of stimulant medications, since they are structurally very similar to other well-known stimulants of abuse, such as cocaine and methamphetamines. Some kids may be prescribed a non-stimulant medication, like Strattera, which is actually a selective norepinephrine reuptake inhibitor, meaning that it's a norepinephrine agonist. Though this medication doesn't have the potential for abuse and doesn't have as many side effects as stimulant medication, its efficacy is questionable, and it doesn't seem to be as effective in treating ADHD as the stimulant medications. There are some effective psychological treatments. For adults, CBT is effective. It works to help the person organize their activities and structure their day, which adults with ADHD have difficulty doing. CBT would also help break down multi-step activities into briefer and more doable portions. In kids, parents and teachers may work to help manage the child's behaviors through operant conditioning procedures, reinforcing kids when they are engaging in acceptable behaviors and either ignoring or punishing unwanted behaviors, usually through the removal of privileges or through timeout. The best psychological treatment that can be used to help kids with ADHD is actually parent training, though this can be somewhat difficult to apply. This treatment is directed toward the parents of ADHD. It teaches them skills and techniques that they can use to better manage their kids' behavior, such as how to prepare the kids for transition times or how to effectively utilize timeouts. This can be very effective, especially when combined with stimulant medication. The difficulty here is that the parents must be willing to get involved, and some parents are unwilling because it makes them feel like there's something wrong with them or it's their fault that their kid has ADHD. Though that's not the case, it might be difficult to engage a parent in this type of training if they have those thoughts. Additionally, many people even state that they would rather have a quick fix for their kids' behavior simply through medication. Next, we'll discuss autism spectrum disorder. This disorder includes people who used to be separately diagnosed with autism and Asperger's syndrome, along with a few lesser-known diagnoses. Thus, the Asperger's diagnosis no longer exists, and they instead are now diagnosed with autism spectrum disorder. As we discuss the symptoms and diagnosis for autism spectrum disorder, I'll indicate how autism and Asperger's used to be differentiated. However, both include deficits in social communication and engaging in restricted and repetitive behaviors, which are the two major categories of symptoms for autism spectrum disorder. First, with regard to persistent deficits in social communication and social interaction, there must be deficits in three major areas. The first is that the person must demonstrate deficits in social emotional reciprocity. Reciprocity means back and forth. Usually there are mutual exchanges in socialization and in emotions during social interactions. For example, if I initiate a conversation with you, you are likely to respond and engage back with me. Or if I share emotional expressions with you, even simple things like smiling at you or giving you a hug, you're likely to return that smile or hug. Or if you're sad and crying, my emotional expression is likely to change in response to that, as I share in that emotional expression with you. Those are examples of emotional reciprocity. People with autism spectrum disorder have deficits in these areas. They may not be apt to ever initiate a conversation or social interaction with you. And if you attempt to engage them, they may only give a one-word answer and not keep the conversation going, or they may not respond at all. Thus, conversations are likely to be one-sided where they might not engage with or respond to your attempts to speak with them. Or they may be speaking with you but never pause to allow you to contribute to the conversation. It's more likely that they're speaking at you and not expecting you to join. The normal back and forth of conversation tends to be lacking, and this may be because they don't fully understand the typical give and take of conversation or interaction. For example, they may also demonstrate difficulties responding to social cues, such as when to join into a conversation or knowing when the conversation or social interaction is ending. There's also a reduction in sharing of interests and emotions. Whereas when many kids are interested in a toy or activity or excited about something, they look to share in that experience with their parents or their friends. Kids with autism spectrum disorder are more likely to engage in that activity by themselves. In many ways, this specific symptom may look similar to what we could see in kids with reactive attachment disorder. But kids with autism spectrum disorder do not necessarily have a history of neglect, and they also demonstrate many other symptoms that are not seen in kids with reactive attachment disorder. With regard to deficits in nonverbal communicative behaviors used for social interaction, people with autism spectrum disorder have trouble understanding the use of nonverbal behaviors that we frequently use to communicate. They may demonstrate poorly integrated verbal and nonverbal communication, meaning that their nonverbal behaviors are not aligning with their verbal communication. They may use exaggerated or strange hand gestures that don't seem to match up with their verbal behavior. They may fail to make good eye contact, lacking the understanding that we use eye contact for communicative purposes. They may also fail to use other facial expressions or nonverbal gestures, again, because there's a deficit in understanding their importance and their communicative function. In some kids with autism spectrum disorder, we may observe that there is a lack of joint attention, meaning that they have difficulty using and understanding nonverbal gestures to share in the focus of an object with another person. An example of this is to think about if a person you were talking with suddenly moved their eye contact to another location. Would you be likely to follow their gaze to see what they were focused on? You probably would. Or more explicitly, if the person you were talking with pointed at something, would you follow their finger to see what they were pointing at? You almost certainly would. This is joint attention. You are following the other person's communicative signals so that you are both attending to the same thing. This is a skill that we tend to develop very early on in life, and other animals such as dogs have this skill as well. However, some people with autism spectrum disorder lack this skill, again providing evidence for deficits in nonverbal communicative behaviors. Finally, in the areas of deficits in social communication and interaction, we must see specific deficits in developing, maintaining, and understanding relationships. We may see that kids with autism spectrum disorder prefer solitary activities and spend time playing by themselves. If they are playing with another kid, it's more likely to see parallel play, where the kids are playing next to one another but not actually with one another. When kids with autism spectrum disorder do have an interest in relationships with others, they tend to be more drawn to younger or older individuals rather than same age peers. There are frequent deficits in imaginative play where kids have difficulties using objects in alternative ways or play in make believe. Finally, we tend to see difficulties adjusting behavior to suit different social contexts. What's meant by this is that we see this rigidity or fixedness of behavior across diverse contexts, indicating that the child is following these set of social rules and doesn't understand that behavior should be altered in different social contexts. For example, the child may have learned that when you meet a new person, you introduce yourself and shake their hand. The child may continue to do that every time they see that person, even though they've met several times. Again, as a reminder, to meet the criteria for deficits in social communication and interaction, the person must demonstrate difficulties in all three of these areas. The other major category of symptoms for autism spectrum disorder is that the person demonstrates restricted, repetitive patterns of behaviors, interests, or activities. There are 4 possible symptoms, at least 2 of which must be met here. The first is that the person demonstrates stereotype behavior, which means fixed, repetitive, and purposeless behavior with regard to motor movements, use of objects, or speech. Repetitive motor movements seen in kids with autism spectrum disorder include constant toe walking or engaging in self-stimulatory behaviors like hand flapping. To be clear, toe walking is not necessarily an indication of autism spectrum disorder, but many kids with this disorder engage in that behavior. Self-stimulatory behavior, sometimes referred to as stimming, is also commonly seen in this disorder. This refers to repetitive and purposeless motor behavior that the person engages in often, possibly because it causes a pleasurable sensation. Common examples are spinning, rocking, or hand flapping. Many little kids do this when they get excited, but it's a behavior that the kid grows out of at a pretty early stage. However, this type of behavior can persist in kids with autism spectrum disorder. We can also see more extreme self-stimulatory behavior, such as banging one's head against the wall or self-biting. Examples of repetitive use of objects are things like lining up toys over and over or spinning the wheels on a toy truck over and over. So the kid is playing with the toys, but not in the way that they're designed to be played with. Instead, they're being used in a repetitive and non-functional way. Repetitive speech is seen with regard to echolalia, which we discussed in schizophrenia. Remember that echolalia is the repetition of verbalizations in a non-communicative way. Kids with autism spectrum disorder may also frequently repeat idiosyncratic phrases that again are not being used for a communicative purpose. Next, there is an insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior. Many kids with autism spectrum disorder can become very upset if their typical routine is altered, even very slightly. They can experience extreme distress at small changes or deviations from routine, and have difficulty transitioning to doing things in a new way. For example, they may need to eat the same food every day or take a certain route or to a specific place every time. This may have developed ritualized greeting rituals, where they greet new people in exactly the same way every time. Next, we see highly restricted, fixated interests that are abnormal in either intensity or focus. It is common for kids with autism spectrum disorder to be very interested in a topic, to the exclusion of everything else. An example would be trains. A kid with autism spectrum disorder may be so interested in trains that they know everything about them and only want to talk about and play with trains. They are uninterested in anything else. While many kids are interested in trains, they tend to also enjoy and be interested in other things too. These alternative interests may be lacking in kids with autism spectrum disorder. So this interest in trains would be abnormal in intensity. Alternatively, some kids with autism spectrum disorder have an unusual preoccupation with objects that is not commonly seen among other kids. For example, a kid with autism spectrum disorder may be particularly interested in vacuums, which is not a common object most kids focus on. This would be an example of abnormality in focus. Finally, people may demonstrate hyperreactivity, meaning overly reactive, or alternatively, hyporeactivity, meaning not reactive enough. to various sensory aspects of the environment. For example, some kids may be overly sensitive to lights or sounds and not be able to tolerate bright lights or loud sounds. On the other hand, some kids may appear indifferent to temperature or pain. This symptom could also be demonstrated by unusual interest in sensory experiences, where we might see a kid engage in excessive smelling or touching of an object. Again, at least 2 of these 4 symptoms must be demonstrated for this aspect of the criteria. Finally, these 2 categories of symptoms must be present in the early developmental period. While there is not a specific age stated in the criteria, typically these symptoms are recognized in the 2nd year of life, where parents start to notice language delays or abnormalities, lack of social interest, and odd play patterns. These symptoms must also cause significant impairment in functioning. Importantly, autism spectrum disorder must be diagnosed according to 2 specifiers. It needs to be noted whether or not the individual has intellectual impairment and language impairment. So the technical diagnosis would be autism spectrum disorder, with or without accompanying intellectual impairment, and with or without accompanying language impairment. These specifiers are now used in place of the separate categorical diagnoses, like Asperger's syndrome. Previously, autism and Asperger's were differentiated by language deficits. Both disorders included difficulties in social interactions and demonstrations of repetitive and fixed interests and behaviors. However, autism also included language impairments, while Asperger's did not. Now they are diagnosed under the same categorical disorder, but differentiated through use of these specifiers. People who previously were diagnosed with Asperger's are now instead likely to be diagnosed with autism spectrum disorder without intellectual or language impairment. People who were previously diagnosed with autism are now instead likely to be diagnosed with autism spectrum disorder with language impairment. They may be diagnosed with or without accompanying intellectual impairment. There is actually not really very specific criteria for determining whether or not the individual experiences intellectual or language impairment. Generally, intellectual impairment would be diagnosed if the person experiences difficulties with intellectual functions, similar to what would be seen for intellectual disability. With regard to language impairment, this would be diagnosed when the person demonstrates difficulties in communicative verbal language, such that they're not able to appropriately engage in verbal interactions with others. To better understand many of the symptoms of autism spectrum disorder, there are a few videos that I would like you to watch. To do this, please navigate to the web page noted on this slide, which is resources.autismnavigator.com. You will need to log in order to view the videos, so you may either create your own account or use the login name and password provided. Once logged in, please click on the link for the ASD video glossary. There, you will see purple tabs on the left side of the web page that will take you to various sections. Specifically, please navigate to both the social communication and interaction section and to the repetitive behaviors and restricted interest section, and watch the videos that I have indicated on this slide. Each video is just a short snippet of behavior. Some of these videos will actually be of typically developing children, so that you have something to compare it to. You'll see that I've indicated which page of videos to watch within each subsection. Each page contains 2 videos. Unless indicated otherwise, I want you to watch both videos on each page. Please feel free to watch other videos included on this website that I didn't specifically ask you to watch as well. Around half of the people diagnosed with autism spectrum disorder are thought to demonstrate significant impairment in cognitive abilities and would be diagnosed with the intellectual impairment specifier. On the other hand, you may have heard of autistic savants. These are people who have an autism spectrum disorder diagnosis, but who show these incredible cognitive abilities, such as being able to do complex math in their head in only a few seconds, or knowing exactly what day of the week any given date fell on, or being able to reproduce a musical piece exactly after only hearing it once. While this ability does exist in a few people, it is very rare. It is much more likely for the person with autism spectrum disorder to have cognitive impairments than to have savant abilities. The overall prevalence rate of autism spectrum disorder is 1%, and it is more common among boys. You may have heard people saying that autism spectrum disorder is becoming more common. While it's true that prevalence rates have increased, it's not clear that the actual existence of the disorder has increased. Instead, it's more likely that it's just better recognized now. Sure, a generation or so ago, there were many fewer people with an autism spectrum disorder diagnosis. But that's not necessarily due to these symptoms becoming more common. It's just that it's more likely now that parents will seek out diagnosis and treatment when their kids display these symptoms. And again, clinicians are better at appropriately diagnosing it. We are still trying to develop a good understanding of the causes of autism spectrum disorder. And I'm sure you're aware that some proposed causal factors are highly debated. Specifically, you've probably heard the claim that vaccines cause autism. This is purported to be due to mercury toxicity from the vaccines. This claim arose from a publication from a doctor named Andrew Wakefield that claimed evidence of a link between the MMR vaccine and autism. Since then, many studies have tried to find additional evidence to confirm this link, and none have been able to do so. Wakefield's paper claiming the link has been retracted following evidence that portions of the manuscript had been falsified. In fact, Andrew Wakefield has also been barred from practicing medicine. So to be clear, there is zero scientific evidence that autism is caused by vaccines. Instead, causes appear to be genetic and/or otherwise biological in nature. There is evidence that risk for autism is increased in a child when a biological sibling also has autism, indicating genetic risk. It also appears that there might be a correlation between age of the parents when the baby is born and risk for autism, providing evidence that genetic mutations that might be more apt to occur due to advanced parental age may be implicated in autism spectrum disorder. It's been proposed that deficits in the amygdala, which is the part of the brain involved in emotions, may also play a role in autism. This may make sense as it would explain difficulty communicating and understanding emotions, as seen in kids with autism. Another possibility is that people with autism have deficits in oxytocin, which is a bonding hormone. This would explain difficulties developing social relationships. Finally, some people claim that autism symptoms are exacerbated, or perhaps even caused by, problems with gastrointestinal functioning. Specifically, that people with autism are not able to effectively metabolize gluten, resulting in heavily concentrated byproducts of gluten that leak into the blood from the intestines, causing behavioral problems. This is based more on anecdotal evidence than scientific data, though. In terms of treatment, there are no good medications for autism spectrum disorder. Medications may be used to manage certain behaviors, like aggression, but they will not cure the disorder. Some parents opt to implement a gluten-free diet and report improvements in certain symptoms. But again, this is more anecdotal than anything. The main treatment recommended for autism spectrum disorder is something called ABA therapy, or applied behavioral analysis. This treatment is very time-intensive. It is not a typical 1 hour a week therapy. It is most effective when the child receives many hours of intensive treatment for weeks in a variety of different environments and contexts, including the home and the school. Unfortunately, many insurances will not fully cover this treatment, and there is also a lack of providers effectively trained in this therapy, so it can be difficult to obtain the necessary level of treatment. ABA therapy works on operant conditioning principles of reinforcement, and it utilizes discrimination training and shaping. Discrimination training is simply teaching the child which stimuli or responses are associated with reward and which are not. For example, making eye contact on request is rewarded, or appropriately identifying which of several options is a shoe is rewarded. This involves many training trials and repetition. Shaping involves teaching a behavior through successive approximations of the target behavior. What this means is that the initial aspects of the full behavior are rewarded at first, until the child can consistently produce that response, and then the target behavior shifts to be more closely aligned with the full behavior. And this continues until the child can produce the target behavior on cue. Let me give you an example of this. Let's start with training a dog to roll over. When I say roll over to a puppy, is the puppy going to roll over? No. I need to teach him to do that using successive approximations of the target behavior of rolling over. To start with, I'll say roll over, and then make my dog lay down. This is the first step in what the dog needs to do to roll over. The dog will get a treat as a reward each time he lays down when I say roll over. When he does that consistently, now I'm going to move the benchmark to a closer approximation of the target behavior. Now he only gets a treat when he lays down and rolls onto his side. When he does that consistently, again, I move the benchmark so that he only gets the treat when he fully rolls over. We can generalize from this example to people. Let's say that we are trying to teach language skills to a kid with autism spectrum disorder. For example, we're trying to get him to say apple when we show him a picture of an apple. At first, he might be rewarded if he makes any noise at all when we ask him to say apple. When he does that consistently, now we move the benchmark so that he only gets a reward if he makes a sound that mimics the first sound of apple. So if he says ah. When he does that consistently, then we move the benchmark to where he is only rewarded if he says app. And then finally, he is not rewarded until he fully says apple. I hope you can see that this is why this treatment needs to be intensive and long-lasting. Training these kinds of behaviors and skills takes a long time and necessitates a lot of repetition. However, this treatment can be very effective, especially for teaching some language and social skills, and also in eliminating unwanted behavior, such as self-injurious behavior. I've included a link to a brief snippet of ABA therapy on this slide, which I will post on the video handout later. This video shows ABA work with a kid who has clearly been in treatment for a while, but you can see the various types of behaviors and skills that are being worked on, and how positive reinforcement is working.